Thank you, everyone. I'm really excited to join this session with my esteemed colleague, Dr. Eugenio McCreary. I think the panel ahead of us was a tremendous discussion that is a perfect segue into what we'll be talking about today, which is the evolving SMA phenotypes in the sitting population. I think it's a privilege today because I get to officially acknowledge and everyone that is an International Persons with Disabilities Day. And so it's timely for us to be able to present this. Here are our disclosures. So in the next few minutes, we want to talk about the objectives today, and that includes kind of the historical SMA classification that you heard from yesterday, as well as outcomes that we typically use to assess sitters. And then most importantly, the factors that may impact disease trajectories. In looking at this, you heard from Dr. Finkel how important it was to understand the natural history for sitters. And so we'll give you a glimpse of what we currently know and what we are looking at in regards to those trajectories, as well as the current changing trajectories based on the factors that are impacting change. And so when we're looking at the changing landscape, we want to define what are the pivotal moments in SMA that has changed this landscape. And one of them happens to be the standards of care. There's multiple standards of care that has been written and published, but particularly the one in 2007 impacted standards of care, particularly for those who have SMA1 with the proactive use of non-invasive ventilation nutrition. And then more recently, Dr. McCreary and Finkel talked about new treatments and approaches yesterday. And so we know the approval of Spinraza in 2016, Zolgensma 2019, and Risdiplam this year has drastically impacted these changes. And we are aggressively and quickly learning as we go on how these are impacting the natural history and the changing trajectory in this patient population. And of course, when we're looking at treatment, how do we as clinicians view and perceive the paradigm of treatment? You could see historically with the standards of care, we went from a reactive model to a more proactive model of decision-making to what we really believe now is an anticipatory care model. In understanding this anticipatory care model, we really need to kind of understand the factors that play a factor in what may change. And so Dr. McCreary and I will try to highlight those in detail today. Okay, so quickly on the classification of SMA. Historically, type 2 SMA has an onset of 7 to 18 months. And patients with SMA2 can sit independently, but not able to stand with a shortened lifespan. We know that the SMN2 gene copy number is highly associated also with the type. And so for unlike those with SMA1, where there's typically 2 copies, in SMA2, typically they have 3 copies of the SMN2 gene. And when we're talking about sitters, I think with this changing phenotype, we're moving a little bit away from these classical definitions because there's different types of sitters. When we think about the classical sitters who never obtained the ability to stand, there's also sitters like Dr. McCreary mentioned yesterday who lose the ability to walk. And so those patients may be adults, maybe a little bit older and have a longer disease duration. So we think about different factors that may impact this. This may be impactful for those who lost the ability. Then there's implications of sitters with disease duration and treatment, such as the shifting nomenclature for the SMA1 type that ends up obtaining sitting. And I think as you go into your breakout groups, you'll have a lot more discussion about these types of changing trajectories, especially as it comes to scoliosis and contracture management in this patient cohort. Of course, we can't talk about trajectories without looking at clinical outcomes. And this is a moving target in the sense of what we need to know and what we are learning on what we need to assess during clinic. But a really good guide is this clinical trial readiness toolkit that was distributed by Cure SMA. And they describe what outcomes are typically used and validated in SMA2. And so highlighted here in green, you'll see that the Hammersmith and the RULM, which we've have talked about in the previous CME seminar from last year. If you would like more information about that, please feel free to reference that. And we do give thorough discussion and understanding on how to administer those tests. But those are the typical outcomes that are used in the sitting population, in which Dr. McCurry and I will expand on a little bit in the next few minutes. Other measures that have been used is the MFM32, which has been used in the Roche trials, and then the EK2. This has been typically validated and used in Duchenne muscular dystrophy. However, it's also a good patient-reported outcome tool, and that has a couple of observation items that we found pretty useful also for those who are non-ambulatory. So when we're looking at factors that impact trajectories in SMA2, what are we looking at that is impactful? Some of the variables include standards of care, age, baseline functional status, that includes disease duration, contractures, scoliosis, muscle imbalances, as well as those muscles that are spared. And with the previous discussion about ethics and center of care acknowledgement of disease, I won't spend a ton of time on this topic of standards of care because you'll dive into it a little bit deeper in your breakout sessions. But I think the thing to remember is to keep the patient and the families at the center of our discussion. And the data points that we provide you today allows you to shift from your clinical hat to your scientific hat so that you can provide patients with the knowledge base to help them be a contributor in making the decisions that are appropriate for them in regards to what they would like to do for treatment. Okay. So now we'll go into a few articles that have been published about the variables that we discussed that may impact the changing trajectory. So here's an article from the ESMAC group that looks at age and baseline functional status. The data from this study has 267 patients with 652 Hammersmith assessments. 541 of them being sitters at 12 months and 267 of them being sitters at 24 months. The age ranged from 30 to 34 years with an average mean age of 9 years. What we found here was there was an average change of about negative 0.68 at 12 months and negative 1.74. As you can see here, when we talk about stability and change, there are small changes within this time frame. However, we found that there is a risk of losing greater than 2 points, and it increases with age. As you can see here on the graph on the right, on the x-axis is age, categorized by less than 5 years, between 5 to 13 years, and then greater than 13. In yellow is the 12-month time frame, and in orange is the 24-month time frame. Gray indicates stability, and as you can just see here, a 30,000-foot view of it is that generally from the ages of less than 5 to 13 years old, patients with SMA2 are pretty stable. About 50% of them or so maintain stability, and even a greater amount of sitters have that stability at the age of greater than 13 years. However, when we move out into the 24-month time frame, this increases where there's less stability, about 10% less in those of up to the age of 13 that has 40%, while we look at those who are greater than 13 years of age with a decline shown in the black of at least 12.5%, that decline of greater than 2 points on the Hammersmith. That being said, each additional Hammersmith point that's lost increases the risk of losing greater than 2 points at 12 months by age groups. We found that 5%, it's increased by 5% in those who are less than 5, and 8% in those who are between the ages of 5 and 13, and those of greatest risk to lose greater than 2 points is 26 points after the age of 13 years of age. So that being said, we also wanted to look at those who are stronger. So we looked at Hammersmith scores of greater than 22 points. We found there's a sharp decline at both 12 and 24 months for this group. What does it mean? It could possibly mean that this these patients are strong, but they reach their maximum functional capacity with their current existing motor neurons. And so, what may be impacting change for these stronger patients could be a contribution of contractures, scoliosis, and possible growth. And that aligns with some of the ages that we're looking at, where we expect some of these changes from a musculoskeletal perspective. And then when SMN2 copy number was looked at, it was not associated with progression. But keep in mind that 90% of the patients in this study had 3 copies. So that would not be able to differentiate well. And then when we look at patterns of progression with the Hammersmith, again, this is with the ESMAC data that was used. We found that from this data set, the ages range from 30 to 63 years old, again with a mean of 9.9 or 10 years of age. We did a shift analysis, and in this shift analysis, it basically dichotomizes the scores into able to do it and not able to do it. So a 0, they're not able to do it, and anyone who received a 1 or 2 got a score of being able to do it. The reason why that we did this analysis is because with patient-reported outcome measures, or what patients perceive as clinically important, they did tell us that being able to perform a task is just as important as being able to do it with the quality as defined by some of the Hammersmith scores. So the gains and losses in the shift analysis will help us kind of interpret some of this real world data. Because some items are susceptible to gains and losses and may be impacted by contractures that may impact their ability to improve or possibly decline. So here on the graph on the right, you'll see that we divided the age groups from less than 5, 5 to 13, 14 to 18, and then greater than 18 years of age. On the x-axis here, you'll see the number of items that were lost, and on the y-axis, you see the percentage of loss. And so you can see here that the greatest percentage of loss of activity are the ages between 5 to 13 years old. And as mentioned before, we're expecting a lot of growth during this time, and so that may be impactful. What we found during this age group is that about 70% of this age cohort lost at least one activity during this time, and then 30% lost 2 or more. When you look at the older, more adult cohort here, you can see that less than 10% actually loses more than 2 activities during this time frame. And then we want to look at the items that are most frequently lost. And what we found here, that's for sitters, between the items of 1 to 22, they're distributed fairly well, except for the ones that we found most frequently lost were items 21 and 22. For those of you who are not familiar with the Hammersmith, this is the supine item where you ask the patient to flex their hips from supine. And this is on the right and left side, and between 7 and 8% lost this function the most. Then when we looked at items that are most gained in this patient population, they happen to be those who are less than 5 years old, but items 10, which is sitting to lying, 6.84% gain to this ability, and item 11, which is the propping on forearms. As clinicians, this may be helpful for us to kind of pinpoint what we may be seeing as the changing paradigm shift with treatment. And so, of course, we have to look at contractures. And there's a nice paper put out by Rachel Salazar in 2018, looking at the PNCR contractures of the lower extremities. What she found is that minimal hip and knee contractures are associated with decreased gross motor function. So you can see here, we're looking at the Hammersmith, and we define low motor function as in less than 10 with the Hammersmith. And the ROC curve shows that hip extension range of motion is associated with low function. And as minimal as 7.5 degrees was associated with this low function, and 9 degrees of knee extension. You could see here that is tremendously affecting our SMA2 population, because over 90% of this patient population had both hip and knee extension contractures. And we can't talk about SMA2 without talking about scoliosis and Cob angle. So this is a paper or a poster led by Sally Dunaway Young, looking at the Cob angle in those who are enrolled in the Cherish and Shine study. And what they found was 73% of the patients had at least 10 degrees of a Cob angle at baseline. And baseline also was a predictor for motor function after nusinersen treatment. And as you've heard before, the younger the patients, the better improvement. So those between 2 and 3.5 years old have the greatest improvement, and those with the lowest Cob angles and with earliest initiated treatment had the lowest Cob angles. And of course, when looking at less than or greater than 20 degrees, those with a lower Cob angle had the greatest improvement in these gross motor functions. And lastly, about spinal anatomy, there was a great presentation by Michael Troy during the Cure SMA clinical conference this past summer. And this is a multi-center study from Boston Children's and Children's Hospital of Philadelphia. They had about 87 patients with SMA2 with and without nusinersen treatment. They found that nusinersen does not ameliorate spinal deformity. However, I found it interesting when they looked at the degrees as well. And they found that those with at least 50 degrees or less, that pulmonary function may change in proportion to the change in stature. However, those with greater than 50 degrees of change, pulmonary function did not change, and that led to thoracic insufficiency. And surgery did not actually modify this relationship because there were irreversible changes to the thorax or the lumbar parenchyma. There was increased thoracic stiffness, parasol rib deformity, tissue scarring, rigidity from the instruments from the surgery itself, and or failure of the surgery to actually improve the mechanics of the diaphragm. So as you can see here, the FDA Approved Therapies has dramatically made changes to the landscape of SMA in both the classification, disease trajectory, and maximal functional abilities that are gained. So now I'll hand it over to Dr. Mucuri, where he'll talk about the changing trajectories.
Thank you, Tina. And I think it's important to say that we are really experiencing some new phenotypes in the non-sitters. Well, actually, we see some sitters who become walkers, and we also see a change in some aspects of contractures and scoliosis and so on. And I think what is important is not only to see how many patients change completely a phenotype going from sitters from walkers, but also to understand how the trajectories are changing, because we may still see patients who will need spinal surgery, who may still see patients who will need ventilation, but what is important to see whether the time or the speed of decline is similar to what we were seeing before the advent of these new therapies. So it's really important that we try to understand on one hand what is available today. You know, Richard, and then you have said several times how important it is to have some reference natural history data for comparison, and also to be able to capture all the aspects when we see treated patients to be able to make a proper comparison. So there is the need to put this data into context to better understand the difference between what we call the old natural history in untreated patients and what will probably become the new natural history with the new treatments, as we have seen in Duchenne with the advent of steroids. So over the last few years, we have been really trying hard to take all our retrospective data, recent retrospective data, until the time when patients started, children and adults started new treatment in order to understand trajectories. And on the next slide, we can see how what are the criteria that we can use to identify patients who may have a different progression, or to identify what is the trajectories in an untreated population. And this is a study that we published last year, looking at a whole population of SMA type 2 patients, and the blue and the orange in this graph only separate patients who had several longitudinal assessments from those who have a smaller number of assessments, but they're all the same cohort. And it's obvious that what we have also seen in other papers, that the progression in type 2 in sitters is different depending on the age when we consider these patients. Because if we look at very young children below the age of 5, we can see that these children are relatively stable, or there is even an improvement because they are growing, they are developing new skills, and they may be able to learn also a better collaboration to improve their scores on the Hammersmith. However, between 5 and 13, there is a very steep decline, and it's amazing to see how by the age of 13, most patients will be with a score below 10. The majority of them will be with a score of 10 or below. So by puberty, most activities on the Hammersmith are lost. So when we look at our data and treated patients, finding stable results over 12 months or even better over a long period has a different meaning, whether we are seeing these results in very young children, or in children in the decline, or in children who are older than 14, because by this time, most untreated patients have very low score and therefore very little possibility to lose further scores on serial assessments. And on the next slide, we see that this applies to children and young adults, but also apply to adults. And this is a PNCR study that show very nicely how the functional status is also important, because the trajectories are different depending on the functional status. In this slide, we can see on the first graph the difference between the natural history, where there was a loss of a mean loss of 1.2 points per year, and the treated patients where there was actually an increase in points, which was over 1 point again per year. And this mean 1.1 point was actually different when the three subgroups were identified according to the functional status, because while non-sitters were practically stable with a minimal decrease in scores, both sitters and walkers showed an increase of over 1 point, which was even larger, slightly larger in sitters. And other scales can be used, and they have been used in natural history studies to understand whether the changes were different according to the type of SMA or to the functional status. And when we look at the sitters, the SMA2 and the non-ambulant SMA3 and the ambulant SMA3, we can see that when we use the rule, there is a lot of variability. The range can, the scores, the changes can range from -7 to +9, but the mean changes were not significantly different between the sitters and walkers, and within the sitters between SMA2 and non-ambulant SMA3. So it's important to have all these results subdivided according to subgroups. And if we move forward to the next slide, we can see that these factors and the progression are also dependent on the baseline scores, because age is important, but baseline scores are equally important. When we look at our longitudinal cohort, we saw that the annual loss were approximately 2 points in our cohort, but the changes were different according to the magnitude of the scores at baseline, because children who were starting with a baseline Hammersmith below 10 points had less points to lose over time, and they were having a mean loss of 1.23 points, as opposed to the one between 11 and 22 points on the Hammersmith expanded at baseline, who lost 2 points, and nearly 3 points on the one who started from more than 23 points. You may remember from the first graph I showed that eventually by the age of 13 or 14, all these children were having very low scores below 10. Why is it important to identify the subgroups? Because it's not only the loss in scores, but also the progression of scoliosis and of respiratory and the need for BiPAP, for non-invasive ventilation. If we look at the three graphs here, at the three subgroups here, you can see that the time when these children reach a Cobb angle of 50 was of 6.6 years in the children who were with a very low baseline score, in the weakest children, and it was 8.4 in the one who had intermediate score, and was above the age of 10 in the one who started with a much better score. So the baseline score can help to predict the time. They will eventually all develop a Cob angles above 50, but a different time. This is largely important on the time of surgery that has to be defined, and also on the progression. And the same applies to the need for ventilation. There was 66% in the weakest one and intermediate group, and only 30% in the group with a higher score. So all these factors are important. We need to look at age, we need to look at functional status, we need to look at baseline scores. And the next one, please. When we think of what are other parameters or other tools that we may use to understand why a child may have a different trajectory, a different progression. We know about age, baseline, functional status, but recently we have also started looking at patterns of MRI changes, of muscle changes on muscle MRI. And these are two MRIs showing a very difficult involvement. In the next slides, there are several more examples that these are all muscle MRIs performed at thigh level. These are T1, all performed in children with type 2 SMA, in non-sitters with type 2 SMA, what were classically defined as type 2. And you can see that just if you look at these pictures, what you see around in the external part of each thigh is fat, subcutaneous muscle. And when you see a darker signal, this is how a normal muscle should look. So the darker the signal, the more preserved the muscle, and the opposite is the more replacement with increased signal you see. What you see is let's say as white on the scan means that the muscle is either atrophic or replaced by fibrotic tissue. And here you can see that age is important, but to a certain extent, because here from the first one on the left going to the right, and then on the second line, you can see there is an increase in the replacement of the muscle and in the atrophy of the thigh muscles. And this is not always dependent on the age. Of course, if you look at the children in the first line on the left, there is a lot of preserved muscle, and these are the children who are more likely to achieve walking or better functional score. So these are other parameters that we may consider in understanding which children have a higher chance of improving their scores or showing much better functional ability. So if we go to the next slide, thank you. What are the conclusion is that we are learning a lot from the natural history study, but there are still a few gaps, especially for adults. There is not a lot published on natural history in adults. And when we talk about adults, we know that we are really including a very heterogeneous group of patients, from type 2 who have never been able to walk, from type 3 who have lost the ability, even type 1 who had been on a tracheostomy and who have become adults. So there is a need for more studies in adults. So this is an open invitation. Anyone who has functional data in adults, please do publish them because they are very needed. And also, it's very important to capture not just functional scales, but also a number of other functional aspects, or in general, other aspects like contractures, scoliosis, need for ventilation, because these are all important not only in care management, but they may also be prognostic factors. And the final aim is to develop a system or an algorithm that may help us to identify more precise trajectories, because it would be great if we could have just a combination of factors that together may help us to identify the children who are likely to have a better decline or less decline, and a better response to treatment. So more natural history, and please more attention in recording what you see in treated patients. Thank you.